and the next talk in the state of the art lectures. The next talk is hepatitis B core antibody positivity. What does it mean for the liver transplant team? And to talk about this, we have Professor John Fung, who's professor and head of liver transplant surgery at University of Chicago, United States. Professor Fung, please talk, please.
Thank you for the opportunity to be here with the Liver Transplantation Society of India. I'd like to thank Professor Panitel for the invitation to present on the topic of hepatitis B core antibody positive liver donors and or recipients and what we consider around the perioperative management of those patients. I have no conflicts of interest to declare. So as you know, hepatitis B is a worldwide problem. There are currently almost 400 million people in the world with a chronic hepatitis B infection, and estimated about 2.5 billion people who have had hepatitis B in the past or currently infected. And as you can see from this picture, the country of origin of study is really the major risk factor. In the United States, our prevalence is pretty low. We only have about 0.3% chronic hepatitis B carriers and 5% that are estimated to be core antibody positive. If we look at the United States, the estimate in our donor population is slightly higher, and we have peaked at about 6% over time of our core antibody positives. And you can see here by time the increasing use of core antibody positive donors. But in other parts of the world, such as Saudi Arabia and China and India, the prevalence of hepatitis B core antibody positive donors is much higher. And this is a study from the Saudi Kingdom of Saudi Arabia, where they looked at 145 donors, and 51 of those were core antibody positive, but surface antigen negative. In other words, these were donors that had resolved their acute hepatitis. And their overall prevalence then of the core antibody positive donors was 35%. And as I noted, most of these donors were from the Indian subcontinent, Pakistan and India, and other countries in the Southeast Asia. And their overall incidence of core antibody positivity was 41%. So in order to talk a little bit about the impact of hepatitis B core antibody positivity in liver transplantation, we really have to understand the replication cycle of hepatitis B and the structure. So hepatitis B was discovered a little bit more than 50 years ago by Barack Bloomberg, for which he won the Nobel Prize. It is a DNA virus of interesting structure. The surface antigen is composed of three types of surface antigen. There is the S antigen, the pre-S1, which is a medium-sized surface antigen, and then the pre-S2, which is the large surface antigen. And obviously there's quite a bit of overlap. The core antigen, the E antigen, make up the nucleocapsid antigen structure where the DNA and some of the enzymes exist within the infectious virion. There is also the X protein, X antigen, which is involved putatively in not only replication of the virus, but also in carcinogenesis and evolution of hepatocellular carcinoma. The replication cycle or infection of the hepatocyte begins with a binding of the surface antigen to a putative receptor on the hepatocyte, which then allows endocytosis of the virion, the extrusion of the nucleocapsid into the nucleus, where the partially double-stranded DNA undergoes one of two pathways. It undergoes closure to a covalently closed circular DNA, or CCC DNA, from which the template then for all subsequent replication of the virus as well as the nucleocapsid and surface antigens are derived from, or the DNA can be integrated. And we won't talk anymore really about integration, except that it is the thought that the integration process is associated also with much of the development of hepatocellular carcinoma. Now, the CCC DNA, as I mentioned, serves as a template not only for the structural protein transcription RNA and then the subsequent translation, but also is a template for the pgRNA, which is the pregenomic RNA, which is a template that is shown in the middle. Here, the pgDNA then becomes the template for the single-stranded DNA, from which then the partially stranded double RNA evolves for the infectious virions. Now, the reason that it's important is this CCC-DNA then exists in an episomal fashion within the nucleus. It's not integrated, unlike the integration I talked about before, but it's very hard then for the CCC-DNA to be eliminated, and therefore serves as a reservoir. And in the core antibody positive donors, as I'll show you, a substantial number of these patients have CCC-DNA. Now, to understand the when we talk about the immune response to hepatitis B, subsequent how we interpret the serologies of hepatitis B resolution, it entails both the cellular immune system, T-cell based, as well as the humoral immune system, which is B-cell based. And here, after viral infections, the antigens are excreted or secreted into the serum, taken up by dendritic cells, and then presented as antigen-presenting cells to T helper 1 cells, and also through the pathway of Th2 and B cell, with subsequent antibody secretion. When we talk about immunity, we generally we have a very hard time to measure cellular immunity. So therefore, we really look to the B cell component in terms of how we assess the resolution and the subsequent markers of B cell HBV infection. So in this timeline, in the acute infection, you see the secretion of the surface antigen as well as the infectious virions. The first marker is the IgM hepatitis B core antibody. Eventually, the IgM HB core antibody goes away, and the IgG anticore develops. And so the total anti-hepatitis B core antibody in late phases is comprised of IgG. And then eventually hepatitis B surface antibody is secreted as the antigen goes away and the infection resolves. So it's important to know that the core antigen is not excreted. It's not found freely in the serum. As I mentioned, it is a marker of replication of HBV, and IgM core antibody is a marker of acute infection or resolving infection, whereas hepatitis B core IgG is a marker of past infection. And high titers suggest there's still ongoing replication of HBV. So this table is pretty classic. You see when we talk about this in infectious disease. If there is surface antigen present, it constitutes either acute or chronic hepatitis B. And these are not the patients we're talking about for donors. We're talking about those patients that are surface antigen negative and hepatitis B core antibody positive. These are people who have resolved or recovered from their acute infection, or either medium-term or long-term afterwards. In some cases, the surface antibody can go away. It's either a false positive or a remote infection that's resolved in a patient or donor with IgG hepatitis B core antibody. So we know that from studies where hepatitis B is endemic, the rate of hepatitis B core antibody positivity changes with age. And so as the population ages, you can see here in this Spanish study, the older the population, the higher the incidence of core antibody positivity. We can see that from this same study, the difference in the age 51 in the core antibody positive versus 39 in the core antibody negative group. But you can see that the liver function tests were exactly the same. All other parameters were really not statistically significant. And so these organs function just as well as patients when you look at risk adjustment as the core antibody negative patients. So the first question that when we talk about hepatitis B and resolution of the acute infection is that really hepatitis B never goes away. I already mentioned that in a substantial portion, the CCC DNA exists as episomal hepatitis DNA within the infected nucleus. And what controls the hepatitis B is the external immune environment. The virus isn't cleared entirely, but it's basically suppressed. So these are the way DNA, HBV DNA can exist primarily as the cccDNA, or which is a reservoir for reactivation. And occasionally you can see this integrated into the host genome. There is some question whether or not there was an extrahepatic reservoir of hepatitis B DNA. We'll talk a little bit about that later. And this is really just showing the role of the immune system in suppressing viral replication. Now, this is a complex picture, but really what it shows is a summary of what we know of what suppresses the generation of active HBV replication in an infected hepatocyte that has cccDNA. So there are a number of factors that suppress this viral replication or reactivation. These are all the interferons as well as tumor necrosis factor. And when these are blocked through different types of chemotherapy agents, biologic agents, as well as other factors, you can see that the interferon responsive genes, as well as other factors like the histones, then allow the virus then to start its replication process. But it's the cccDNA that exists that is a reservoir. All of these other substance pathways have an effect on the external immune system. You can see here, talk about B cell therapies, we talk about cytokine inhibition, immunosuppressive agents, steroids, etc. These types of agents all have an effect on the external immune surveillance of the hepatitis B, and therefore any of those pathways, when they're interrupted, can lead to hepatitis B reactivation. So in the setting that we're talking about here, which is a donor that is hepatitis B surface antigen negative and core antibody positive, the concept of reactivation in this population is that the DNA becomes detectable and the surface antigen then becomes secreted. And this is basically the concept of occult hepatitis B infection from a reservoir that otherwise is relatively dormant. So the first suggestion that these livers could be a source for occult hepatitis B infection came from the French group, where they looked at, in retrospect, a number of patients 207 patients who were hepatitis B negative, but then 20 of those then went on to develop hepatitis B post-transplant. They went back and they found that a substantial portion of those really were infected pre-transplant. But they had found that 13 of them received a core antibody positive donor, of which 6 of them converted to hepatitis B, active hepatitis B replication. And so this was the first report that suggested that HBV infection could result from the use of core antibody positive donors. And then the Colorado group by Wax showed that in 25 patients, donors that were hepatitis B core antibody positive, when they used those organs, that the liver patients seemed to be the most vulnerable in terms of the risk for the de novo hepatitis B. And you can see the risk in the kidney and hearts was substantially lower. And this is thought because the cccDNA that I just talked about resides within the liver, doesn't reside in the kidney, doesn't reside in the heart. And so use of those organs is generally considered safe. Now, the NIDDK, Raleigh-Dixon's group with the NIDDK went back and looked at their 23 recipients of livers from core antibody positive donors that were HBV negative. And what they found was 18 of them, or 76% of them, actually ended up with hepatitis B. And in contrast, in those same population receiving 651 core antibody negative donors, only 3 of them became infected. And you can see here hepatitis B chronicity was evident even as early as 1 year, and then by 5 years, most of the patients showed chronic active hepatitis from B, and the overall 4-year survival was diminished with a hazard ratio of 2.4, and therefore they concluded similarly that donors that were hepatitis B core antibody positive had a risk of transmitting de novo hepatitis B to a non-infected patient. Our group in Pittsburgh went on then to validate this in our population of 140 liver transplants that received a core antibody positive. But then we also stratified those patients that received those livers by their own hepatitis B serology. And what we found was that patients that were hepatitis B surface go a step back. Donors that were hepatitis B surface antibody alone didn't transplant, and these were immune donors. So only surface antibody positivity didn't transmit. Patients that had donors that were hepatitis B core antibody positive transmitted to naive non-prophylaxis patients at a rate of 72%, which is consistent with the NIDDK. And what was interesting was when we had recipients that were immunized or had hepatitis B surface antibody, the use of core antibody positive donors did not transmit hepatitis B. And patients that were positive for only the core antibody positive, in other words, the recipients were core antibody positive, when they received a core antibody positive donor, they reactivated the hepatitis B 13% of the time. So the recipients, when they were either surface antibody positive or core antibody positive, retained some immunity to subsequent use of core antibody positive donors. And this is also shown in this study where you can see this, if the recipient was surface antibody positive or core antibody positive, the rate of developing de novo hepatitis B was 0 in this study, substantially lower than when the recipient was seronegative for hepatitis B surface antibody or core antibody, where almost 60% of the patients developed de novo hepatitis. And you can see this is the timeline in terms of when they get infected, and by 2 years, most of the patients had already developed de novo hepatitis. So in the summary of this meta-analysis, looking at the serology of the recipient, you can see that those patients that were naive had a 77% risk of developing de novo hepatitis. Those patients that were positive for the surface antibody and the core antibody, the recipients had no risk of acquiring de novo hepatitis. Patients that were surface antibody negative but core antibody positive had 13%, and those patients that were surface antibody positive, core antibody negative, had 18%. And I'll talk a little bit about this in the next few slides. The reason I bring this up is because most centers don't quantify the surface antibody titer. And this is a study that a meta-analysis again from a UK group, from Andy Burrow's group, that validated what I just showed you in the last slide: high risk of hepatitis B de novo in naive patients. In those patients that were core antibody positive, surface antibody positive, very low rates. Those patients that were core antibody positive but surface antibody negative, lower rate, and then those patients where surface antibody also had a 10% rate. But as I mentioned, the surface antibody is rarely quantified. And in this study from China, looking at 230 patients receiving hepatitis B core antibody positive grafts, what they found was the surface antibody, if it was greater than 100 units per liter, the transmission rate was 0, whereas it was 20% when the titer of hepatitis B surface antibody was low. And this is important as we talk then about our strategy of how to use core antibody positive donors safely. So summary of the slides I just showed you: if the recipient is core antibody positive, surface antibody positive, no need for prophylaxis, very low risk of using a core antibody positive donor liver. If the core antibody positive donor and surface antibody negative, we generally will prophylax unless we can seroconvert them to surface antibody positive, and we'll talk about that. Patients that were surface antibody alone but core antibody negative, these were patients who were vaccinated, may need prophylaxis, but depends on the surface antibody titer. And if it's greater than 100 units per liter, it's generally considered very low risk, and prophylaxis may not be necessary. Obviously, the naive patients, the risk of de novo hepatitis is quite high, and these patients all should be prophylaxed. So the question is, what is the right prophylaxis? And this is a survey that was done several years ago, looking at the use of prophylaxis by different programs in the United States. Many of the centers use a short course of HBIG and then long-term lamivudine. The next was lamivudine alone indefinitely. The next was combination of HBIG and lamivudine indefinitely, and then another one of just HBIG at the time of transplant and lamivudine indefinitely, or HBIG alone and no lamivudine. Now, how efficacious are these protocols? Well, this is HBIG monotherapy alone. You see in this study, the 3 out of 10 patients that received HBIG alone did get hepatitis B, whereas if they also had other markers of pre-immunity, they didn't. If you use lamivudine alone, at least in the short course of 1 to 69 months follow-up, no reactivations in this summary, as well as a combination of HBIG and lamivudine, no de novo hepatitis. But having said that, I think when we think about now our strategy, and this is how we look at it at the University of Chicago, if we have a patient that's surface antibody negative, we will pre-vaccinate them in order for them to be protected against subsequent hepatitis B exposure, but also to allow them to be considered for hepatitis B core antibody positive donors. If the patient is not able to be vaccinated, it has no immunity, then they will receive HBIG at transplant and then long-term nucleoside analogs. And particularly if the donor has some marker of HBV DNA positivity, either NAT test is positive or there some other marker that they may be more than just a core antibody positive donor, then we will also give them long-term nucleoside analogs. If the recipients are core antibody alone, we give them long-term nukes. And if they're surface antigen positive, greater than 100 units per liter, we don't prophylax them. We also have a protocol to eliminate steroids within 1 week after transplant, and this is because the HBV has a glucocorticoid responsive element, which is stimulated by corticosteroids to upregulate HBV replication and infection and synthesis. So one of the things that I think is very intriguing, and this now may reach reality, is some work that Danny Shuval did when in Israel with a company in making a vaccine which is different than our current vaccines, which are current vaccines are S antigen vaccines, and what he has developed is a pre-S1, pre-S2 S vaccine. So looking at the big particle, and what they found was using this new vaccine, the titers that are protective titers was reached more quickly, and then also sustained at much higher levels in terms of HBV antibody titers compared to the Engerix lot. And so that's shown in here. So what we think is that the potential use of a more powerful vaccine for the hepatitis B surface antigen and its pre-1, S1 and S2 potentially can make these patients even better protected when vaccinated at the time before the transplant. So at the time of transplant, they can get a core antibody positive donor. I think the research areas in this relate to some of the new new markers in monitoring patients for HBV infection and reactivation. These include measurements of hepatitis B core antibody titers, measuring hepatitis B core related antigen, and the core related antigen is thought to be a better marker of intracellular hepatitis C cccDNA. It's much cheaper to do than measuring cccDNA and hepatitis B DNA. So it may be a surrogate marker for HBV reactivation. And then the pregenomic RNA, there are assays now that can actually measure HBV pregenomic RNA, which is a immature virion before it's transcribed and reverse transcribed into the partially covalent double-stranded DNA. So applying these new biomarkers in the setting of using core antibody positive donors, I think will be very exciting and may be able to predict those patients who don't need a prophylaxis. Now, just to spend the last couple of slides talking about the recipients and their risk when they're core antibody positive. The only thing I can really say is this is a group of patients who are core antibody positive, surface antigen negative, 104 of them, that were not prophylaxed in any way. And what they found were that 2 of these 104 developed de novo hepatitis within 1 year after transplant. So it's not clear whether or not they got it from the donor or they got it from the recipient. The recipient donors were all by standard markers negative, but still it's possible they could have transmitted from the donors or blood transfusions. But what was interesting is they also looked at part of the study, 25 other patients, and then they were able to identify HBV DNA, not unexpectedly, 20% in the liver biopsy, but 20% had HBV DNA in the PBMCs, in the leukocyte fraction. And so, there's always been some interest or suggestion that the extrahepatic reservoir of hepatitis B could potentially be a source for reactivation. But the summary of this study suggested that the rate of HBV reactivations in people with occult hepatitis B after transplant is low, does not warrant general use of preemptive antiviral therapy, and I would concur with that. I cannot recall a patient who was core antibody positive, surface antigen negative, who received a liver transplant from a non-HBV, who then subsequently got de novo hepatitis. So I think that risk is pretty low. So just to conclude, the use of hepatitis B core antibody positive donors is safe. It can't expand the donor pool. And this proved not only deceased donors, but living donors. And I didn't talk about the living donor experience from Japan, but there's substantial evidence that the core antibody positive living donor is just as you would expect for the deceased donors. The consideration for their use depends on the recipient HBV status as well as the medical urgency. So if the patient's dying, it's not immunized, then we use these core antibody positive donors knowing that the naive patient is at high risk, and we will prophylax them with HBIG and nucleotide analog. The absence of HBV DNA in the core antibody positive donor, as I hope I showed you, does not preclude transmission of HBV to liver recipients. I didn't show you a study that in which transplant centers were asked in a core antibody positive donor, is the presence or absence of serum HBV DNA important? And most centers said well, if it's negative, we'll use it and we don't prophylax. Well, that's the wrong answer. The right answer is core antibody positive donors with or without HBV DNA should be considered infectious and should be applied to the algorithm I just showed you in terms of the recipient HBV status as well as the use of prophylaxis. The isolated hepatitis B surface antibody in recipients may decrease and may eliminate the risk, but it really depends on the titer. So the high titer surface antibody positivity can really substantially reduce and probably not eliminate the risk of post-transplant de novo hepatitis, but substantially reduce it. Recipients that are positive for both the surface antibody and the core antibody, really, we don't prophylax those patients because they are immune. I think talking about what prophylaxis to use, I think that it's an evolution. Lamivudine is cheap, and at least in short term, 1 to 5 years, the risk of reactivation and the high mutation rates associated with lamivudine probably are not a big problem. But if you start using it much longer than that, there is a potential for escape mutations. And so because it's so cheap, it's something that could be considered in most countries. In the U.S., we don't use lamivudine too much anymore. We use it either entecavir or defivir, which have a much higher threshold for resistance as in terms of long-term nucleotide analogs with relatively good safety profile. And I think there is a risk in discontinuing HB-free prophylaxis, at least the way we do it now. And potentially, the biomarkers for HBV that I talked about may be something that will help us safely take patients off of prophylaxis. Finally, I already talked about this, that the recipient with core antibody positivity can receive it with some risk, but maybe low risk. And with that, I am done, and I wish you all the best, and hopefully I'll be able to participate this coming Saturday. Thank you.
Professor, thank you very much. Charles, is he there to answer the questions? Or?
Yeah, he's here. He's online.
Professor Fung, thank you very much for that. It's very clear,
you're
very
welcome.
succinct. Thank you so much. I'm Dr. Sudhindran. We met in person. So,
yes, we've met.
Couple of things. I mean, the lamivudine, because in our own patients, when you're given lamivudine for recipients who had donors with HB core antibody, one of them actually did reactivate, and we've tried to get tenofovir. So, to be very clear, which drug do you now use for recipients of donors with HB core antibody?
You know, so in general, we use entecavir. And tenofovir has some renal toxicity. You know, adefovir and entecavir both depends on your program choice. You know, I do think, you know, the other option of just maintaining patients on lamivudine and waiting for a mutation to occur and then switching them, you know, to new generation nuke probably is very cost effective when you look at a country where you have lots of hepatitis B. In the United States, the reason we go to entecavir with a very high threshold for mutation is because we don't, you know, when the patients go home to their community physician, they often will not monitor hepatitis B reactivation. So it's very easy to send those patients home on entecavir and then not really worry about reactivation and development of mutations. But in a country like, you know, China or India, where, you know, you have so many of your patients that are positive for hepatitis or, you know, core antibody positive donors, just maintaining them on lamivudine, knowing that a percentage of those are going to convert, and then switching them to a new generation nuke probably is very cost effective.
Secondly, is the prophylaxis lifelong?
So some programs will stop at 3 or 5 years. The risk is that if the patient gets any kind of steroid bolus, or for whatever reason they're treated for a rejection later on, they're at risk. They still are at risk for reactivation, and since we don't really study them after 3 or 5 years once they leave the program. It's hard to know, since we don't do liver biopsies, we don't do cccDNA on a regular basis outside of research. There is still the theoretical possibility they can reactivate. But many programs do stop prophylaxis at 3 or 5 years. It depends on the program. We have taken the policy, we continue to treat them, but I can't remember the last time we had an HBV reactivation though, using core antibody positive donor.
So a couple of questions here. I think both have been answered in your talk. One is, if donor HBV DNA quantitative is negative, still you need to do HBV core antibody test. Yes, we do, and we have to prophylaxis them, the recipients, if the recipient is anti-HBs antibody negative. You also mentioned regarding the titer, high titer, low titer. Is it 10 the cutoff, or is it 100? What is your cutoff for treatment?
So it's the cutoff for prevention for what we consider high titer is 100 units per liter. Now, some programs, if you look at the literature, it will drop down. So, there's another study that showed 30 units per liter was protective. If we get to 100, then we don't prophylax. If it's less than that, we will prophylax with nucleoside analog. So it really depends on your program and what you feel comfortable with. But we do give more. In our case, we give the hepatitis B vaccine at double dose, and normally a single dose twice times 2. We give double dose times 3. Include the last dose being they get it at the time of transplant. So it's hard to know whether or not it makes sense. With what I think is exciting is this CyB-Vac, which is a new in FDA. It's in the FDA's. They finished their phase 3 study, and it's with the FDA. They filed the paperwork this year for potential FDA approval of this new pre-S2, S1, and S vaccine, which I think is very exciting. That if that happens, then we may be much more reliable, protective titers in our pre-transplant patients.
There's one question from Dr. M.S. Vishwanathan, interesting question. Do we have the same treatment strategy following pediatric transplant as well, recipients? If the donor is antibody positive?
Yes, this is a good question. I think the pediatric patients, they tend, in our experience, to have the same risk of reactivation. And there was a study that came out of China looking at core antibody positive donors in pediatric liver transplantation. They use HBig short-term prophylaxis and long-term nucleotide analogs, but because the risk of lifelong exposure to nukes is not known, they stop the nucleoside prophylaxis at about 3 years after their transplant. So, and they have had very low, about 10% reactivation, which I think is a reasonable approach when you're looking at children, because we really don't know long-term exposure to the what nukes do in kids.
3 years following transplant for pediatric recipients.
Yes, in peds.
One last question, again, interesting one. In case the recipient hasn't had a vaccination, is it worth giving vaccination after transplant?
Yeah, so the prophylaxis, the conversion rate post-transplant is terrible. If they have, because they're on immunosuppression. We have tried to convert patients to get them off, and this is many years ago, when we tried to stop the HBig and then start you know, this would be even for the days of the nucleoside analogs, without really much success. So there are about a 5 to 7% conversion rate per year with the hepatitis B surface antibody, but overall the efficacy of post-transplant immunization is pretty poor.
Thank you so much, Professor Fung. That was very, very useful. I mean, so many important questions and
Thank you very much
very
for
clear, succinct answer.
It's a nice meeting. Thank you.
Thank you. Thank you so much. Charles, I think no further questions. We can go to the next session.